Hi again. This is part 3 of the Joyful Belly Approach to Pregnancy. In this section, we're going to talk about the perinatal month 9 and labor and delivery. The imbalances that you're going to see during this time period in month 9 will be similar to third trimester. The baby is now moving into the birth canal. There's a little bit more discomfort in walking. The ligaments are still loose. The mother still has all the organs displaced. So it's kind of just reaching the end of the pregnancy, and she's pretty well tired of all the discomfort that she's been put through in the last month or so. Looking at perinatal lifestyle, there are some things that the mother can do to minimize discomfort and to support the impending labor. Weekly chiropractic sessions can be beneficial, especially using the Webster technique. This is a very specific style of adjustment that aligns the mom's pelvis, supports the nervous system and the entire spinal canal, so that she'll be in good stead for labor and delivery. This moves the pelvis into optimal position for birth. It can prevent back pain and aches, and it's just a really nice gift the mother can give herself to feel fully aligned in her body, because she's been struggling with changes in center of gravity and a softening of the ligaments and tendons and other things that may have caused her to feel out of alignment. During this time, she may also want to practice with different positions to see where her level of comfort is. This being the 9th month, she's probably been having kind of practice contractions, the Braxton Hicks contractions, since the 4th or 5th month. So what you can do is, if she's experiencing any of those, is move into some different positions to see how does this feel. Sometimes the position that we labor in, that we're going through contractions, is not the same position that we want to use for birthing. So by being exposed to these different styles, when the time comes for moving into a position that feels really comfortable, she'll have an array of options. One of those options is to be on our hands and knees. And this is kind of, I told you I did the Bradley method, the farmyard method. It mimics that position that many animals use. This takes the pressure off of the pelvis, takes the pressure off the abdomen, and allows that free movement of contractions. In a hospital bed, women are often left on their back with their legs in stirrups. It's not a natural position. As animals, when we're in this position, our belly's exposed and we feel vulnerable. This birthing mother wants to feel protected, supported, nurtured. So looking at different positions that will help to instill that kind of psychological effect can be beneficial as well. She might be sitting on the toilet in a squat position with the knees elevated. That's often very good for contractions. And then she could take a similar position when she goes into labor and delivery, not on the toilet. Sitting in a bathtub. Now this might be a bathtub. It could be a large water tub or a hot tub or things like that. I had a dream of water birth, but for me, my contractions stopped once I got in the warm water. So it didn't last more than a few minutes. But the mom may want to try this. It can be a very comfortable position to labor in, to be surrounded in warm water. It's also a very nurturing way for the baby to be born from the warm water of the mother into the warm water of the bath. It can be a very easy transition that occurs. If she wants to squat but doesn't have the strength in her thighs to maintain that for a time, she might be hanging onto a bedpost or install a rope or swing that she can hold on to that will support her upper body while her lower body is in that squat position. Sometimes you might want to move with your elbows up on a surface like the couch or on the bed, with the knees on the floor. This was the position that I found most comfortable when I got into contractions for delivery. I know women that like to use those yoga balls, and they're on top of that ball for the contraction. It supports the body. They can have the open pelvis. It's not good for birth, not good delivery position, but there are two distinct phases of labor and delivery. There's the contraction phase, which is allowing the body, it's getting the body ready to move the baby into the birth canal. And then there's the birthing phase, where the baby's in the birth canal and ready to move out. The woman may find very different positions which she enjoys for these different phases of labor. While she's got energy and she's got the ability, she might want to cook a few meals. Arrange for help in the house for a couple of weeks. Is that some family member that wants to visit and stay with you that you would like to have there? That's great. They have meal train apps, or this is a really great thing for friends to get onto, is let the friends be the ones planning the foods. Let the friends be the ones saying what it is they can do. Oftentimes people say, let me know if you need anything. Be willing to say, what I'm going to need is meals on Mondays. Would you be willing to take care of meals on Mondays for, say, 3 weeks? And they're probably going to say, sure, I'll do that. Then the next question is, would you be willing to find someone for other days? Put someone else in charge of it. You can be the one asking, which is fine. You may put it out, or the pregnant mom may put it out at the baby shower or the blessing way or other times. But it does take a village, and it's really nice if someone else steps up. And so you might talk with your client about someone that they might speak to about this, who can be that person, who can put people together for food. Now, if they've got other children, or if they have pets, they might want to find a way to have someone who's going to watch them while they're in labor, so that their mind is free and settled and not concerned about where the child is or if the pet's being fed. Put together some healthy snacks for energy. How are you going to stay hydrated during labor? If you're planning on going to a hospital, then you can have a bag prepared that has these healthy snacks in it, lots of water bottles, and anything you think you might need. If it's going to be at your home, you've got easier time. You've probably got your snacks and your water available, but you do want to make sure that you are nourishing yourself and hydrating yourself during labor. Looking at how to breastfeed and get a good latch. Now, you're not yet ready for breastfeeding because you don't have a baby there, but you can read up books. There are resources such as an organization called La Leche League. If you're working with a midwife, she may know of someone in the community who is a breastfeeding coach, and it'd be great to talk to that person about how to support your child in latching on shortly after birth, especially if your client suspects that they're going to be having a cesarean birth. In cesarean birth, back up, during the process of labor, a hormonal message gets sent to the breast to begin the process of letting down milk for nourishing the child. If there's been a planned cesarean and the woman hasn't labored, that hormonal message hasn't been sent, and so her breast may not be prepared when the baby first goes to latch on. So if the woman suspects that she may have a cesarean birth, it would be great for her to talk to a lactation consultant prior to birth, and so that she could be ready with everything in place so that she can have the most successful breastfeeding experience possible. Acupuncture, chiropractor, massage, these all can become very nourishing and nurturing to the mother and help her to minimize any discomfort that she might experience during labor and delivery. Each passing week of pregnancy sees more stagnation in circulation, more sluggishness in Vijana Vayu circulation. Massage can help move lymph. And again, you'd want to be working with a massage therapist who is familiar with pregnancy massage, so they will have you in a position that's comfortable, and be careful to do only those strokes that are beneficial. Acupuncture and chiropractic can be beneficial to ensure the baby's in the right position. Also to take care of any last-minute challenges the mother may be experiencing. During the daily routine, the woman may want to take red raspberry leaf tea. Red raspberry leaf is a uterine tonic. That's its prabhav. It helps to strengthen the uterine muscle, and so I usually recommend that women drink red raspberry leaf tea during the entire third trimester. There's no downside to it. It's not a uterine contractant. It's not going to cause stimulation, but it does strengthen the uterine muscle. She can certainly, if she hasn't been doing it during the last trimester, during the final month would be wonderful. Keep the oil on the belly and the skin to prevent stretch marks and tearing. It's best if she's been doing this through from the second to third trimester, but especially now because the body's going to grow very quickly. You may want to incorporate some devotional and spiritual practices into her day to pacify the mind and the body. I mentioned some birth affirmations here. My body was made to do this. Millions of women have given birth before me. Women have been giving birth since time began. What causes us the most pain during childbirth, what causes us the most difficulty with childbirth is the mindset that resists what the body is going through. So if we have a contraction and we think, oh my God, I can't take this, this is too horrible, we push against the walls of that and it makes it more and more painful. So by using these birth affirmations and trusting the body's process, we are in better position to have a healthy labor and delivery. It is possible that an emergency condition could arise that would belie that the body wasn't made to do that. As my friend I mentioned in the second part, who had the cervix that wouldn't dilate, her body was not made to give birth. But then she trusted that she was in the exact right place to give birth. Her children were born healthy and safely. It was through cesarean section, but that was an emergency and necessary to do. And so although she couldn't say her body was made to do this, the best result of delivery is a healthy mom and a healthy baby, regardless of what the steps were taken to get there. They mentioned it prepares mentally for the pain of childbirth, and they can use this as kind of a hypnobirthing, a repetition during the birth itself to bring themselves back into present moment and calm and relax. Also, during this month, they can really get the home ready for the new baby. If they're going to be delivering at home, they want to consider, where am I going to be delivering? Maybe clean the carpet, clean the furniture, have it be as clean an environment as possible. The nesting instinct becomes especially strong right before birth. And so the person may want to deep clean the house, wash everything, finish up on unfinished projects. Now is the last time she's going to be able to do that without the distraction of the infant. In some way that will pull her attention away from all these other chores. Generally at this time, we follow a vata pacifying diet of easy to digest foods. Mentions here we could take medjool dates in the last month or two, preparing the body for birth. It has an oxytocic effect of hastening childbirth. Oxytocin is a hormone produced at the pituitary gland, which is responsible for a couple of really vital things around childbirth. Oxytocin is the hormone that drives uterine contraction for childbirth. Oxytocin is also the hormone that causes us to bond with what we're looking at. Oxytocin is also the hormone that's going to cause the letdown reflex of the breast milk. So when we think about it, as we're nursing a baby, we're gazing at the baby, and the oxytocin is creating a bond between mother and baby. As she goes through delivery, the body is flooded with oxytocin. So then when the baby is born and she looks at the baby, there's a hormonal connection that increases bonding with the child. This is evolutionary, and it causes us to bond with our offspring. So by having those medjool dates, you've got all the raw materials to build good quality oxytocin, which will support the body in good delivery and also breastfeeding after and bonding with the baby through the entire process. They mentioned the red raspberry leaf tea again. They say don't take in the first trimester as it may encourage uterine contractions, could cause miscarriage and early pregnancy. I've read that before. It's never been my experience. I know lots of women who take red raspberry leaf tea from the get-go because it's sold as pregnancy tea, and so they don't really look beyond the package. They assume that the company that put it together has done the research. If someone is taking red raspberry leaf tea in little tea bags, it's not a problem. The volume of red raspberry leaf that they're getting is so mild that they're not going to increase a uterine contraction. That being said, if a person has a challenge, if you have recommended herbs to a client and they have had a miscarriage, they are most likely to blame your herbs, regardless of how small the dosage was or how minimal the impact would typically be. So my rule of thumb is I usually don't recommend anything other than culinary spices in culinary dosages during the first trimester, because they're not going to suspect that little bit of cumin that they sprinkled on their food caused any problem. But if I gave it in a cumin tea or I had them take a cumin medicated ghee, they might think that it had a greater effect than it was going to have. The first trimester is such a tenuous time in pregnancy that I'm very cautious with it. I make dietary and lifestyle recommendations only. If we go past the due date, past that 40-week period, we can look at some labor-inducing recipes. And he mentions here eggplant parmesan, Aztec hot chocolate, my favorite, and the maternity salad. All of these you'll find online, and you can give them a try ahead of time. There's no harm in eating these for a woman who is not pregnant, but they are certainly beneficial for a woman who's in her 9th month and ready to go. Nitrates are chemicals that one would want to avoid all throughout the pregnancy. These nitrates are found in cured meats, such as lunch meats, or in salami and sausages and things like that. So digesting nitrates in the form of nitrosamines, these are known to be carcinogenic. They transfer very easily into the child's developing body. So because of the fact that they are carcinogenic, because they travel through the body, they don't know what effect they'll have on developing fetuses, and largely because if it does form a cancer, it's going to be years later and you won't look back to the nitrates. You won't think, it was probably that sausage I ate. Because of that, you just want to limit the child's exposure to carcinogens. No smoking, no drinking of alcohol, and no nitrates. Here's some examples of foods that have nitrates: processed meats such as bacon and salami. It can also be found in drinking water in some areas, and I don't know what those areas would be, so that might be a good thing to research if there was nitrates in the water in your area. Probably going to be in more agricultural areas, because you might find nitrates as a runoff from conventional farming. Fruits and vegetables may have nitrates, but that's not usually a problem. Nitrates are nitrogens, and lots of things have nitrogens. What we're concerned with is the types of chemicals that are used in processing meats. So it says here the vitamins in fruits and veggies mitigate the effects. I would say also the fiber. A lot of what we have around us is nitrogen, and nitrates are nitrogen. We use nitrogen in fertilizers, and we use nitrogen in lots of ways. The nitrosamines that they use in curing meats are a little bit different. They've been processed in a different manner in order to cure the meat to make it shelf stable for longer. So we can think of it in terms of, if it's going to make meat shelf stable for longer, what is the impact it's going to have on our muscles? What's the impact it's going to have on our tissues? And is that an impact we want it to have? So we're avoiding lunch meat, soft pasteurized cheeses, raw fish or other raw meats. There's a slight risk of bacterial infection, but this also are difficult to digest with the Agni. We want to make sure we've got this strong Agni, especially early on in the pregnancy. These would be difficult to digest, more kapha increasing. Raw dairy can carry listeria, which because of the weakened immune system, the mother may be more subjective to this opportunistic infection. With the suppression of the immune system, we want to limit our possible exposure to bacteria. And so the lunch meats have the nitrates, but the soft cheeses, the raw fish, and raw meats all have a greater tendency towards bacterial overgrowth. Looking at caffeine intake. Coffee gets a lot of research because everybody wants to justify drinking it. And so there's conflicting studies. Some say it's not so good, and some say it's really good. It's a great antioxidant, and it's an anti-inflammatory, and then people say, no, it doesn't have that effect. It's more acidic, and it's going to be problematic. Ayurveda tends to come down on the side of it's too acidic, and so we would avoid it for that. If we limit it to 200 milligrams per day, if they're talking about, okay, I'd have to do my quick search on coffee and how many milligrams are in a cup of coffee. I think this is looking between 1 and 2 cups of coffee a day. I would love to advise all my pregnant women, I would love to advise everybody to look at their use of coffee and assess, why am I taking it, when I'm taking it, and what is the impact I want it to have? And the next question, of course, is there other ways to get that same action? I'm not a coffee drinker, and so I'm not a good one to talk about all the benefits or challenges of not drinking coffee, because it was never a big thing for me. But I do want to look at what is the impact this is going to have on the nervous system, what is the impact it's going to have on circulation and on the digestive system. And if there's a challenge, too much acidity, drop the coffee. If I'm not sleeping at night, drop the coffee. If my nervous system, if I'm feeling overwhelmed and anxious, drop the coffee. And then we're all addicted to it, so we don't want to drop our coffee. Alcohol should be avoided all throughout the pregnancy. It's passed directly to the fetus. It moves through the system very, very quickly. It affects the fetal liver, and the fetal liver is unable to process out alcohols at that time. And we can produce a condition called fetal alcohol syndrome. And this has a number of physical birth defects, but also a number of psychological challenges. The CDC, or the Center for Disease Control, says up to 1 drink a day is okay while breastfeeding, but none during the pregnancy. If alcohol is taken, during breastfeeding, they would advise the mom to wait until that alcohol is processed out by the liver before she nurses the child. So mom wants to wait 3 or 4 hours after a drink before feeding. What moms can do is use a breast pump and draw milk out before they drink, then they drink. Moms I know that are super cautious of this will pump again after they drink alcohol and throw that milk out. So that's the pump and dump if they feel the alcohol is still in the system. And I've even known some moms who drank a little bit of beer in order to get their child to sleep. So it's, again, you want to look at what's going on, if there's better ways to get the child to sleep. The alcohol is not passed really easily into breast milk, so alcohol is safer when breastfeeding. And I would also say the nervous system of the child is better developed at this time, so you're not going to see any kind of alcohol syndrome. What you might find is it may tax the infant liver, or you may show up with some signs of they'll have some reactions to the alcohol. Their skin, they might get rashes or some kind of pitta type reaction. So the 9th month has come and gone. Now we're at week 40 and we're ready for labor. If we've taken care of our diet and lifestyle during those 8 months leading up to this time, or up the 9 months leading up to this time, then we are in a better place for healthy labor and delivery. But what is the kind of care we can take during labor itself? The mobile guna takes precedence now because the body is moving, the baby is moving. It's going to move from this place where it's been held because of the high progesterone levels out into the world. This can also be a rough time. It may be painful. It says pain maxes out when in transition and when the baby's head is coming out of the vagina. It can also be an exhausting time. So we do have pain. When I always talk to people about my own labor and delivery, and I say it wasn't so much painful. Certainly when the baby was crowning, that was much more pain. But during all of the contractions, I didn't experience it so much as pain as I did intensity. So it was like taking the worst menstrual cramp you ever had, and it magnified it, but then it diminished. And so they would come and go, and if I could live through the intensity of the symptom, it never really moved into pain until there was that movement of something big moving out of something fairly small. It can be very exhausting, often because you can't sleep during the time that you're in labor because the contractions would wake you up. And if labor happens to start, mine started at 2:30 in the morning, and he was delivered at 9:30 in the morning or 11:30 in the morning the next day. So it went from 2:30 all the way through to 2:30, then 7 more hours, so about 31 hours of not being able to sleep for more than a minute or two at a time. Now, early on, I could sleep for half an hour or so as the contractions were going on. But when it came to the end, it was not really possible. This is a vata time. It's a time period of transition and of movement. The Agni may be very low. There's not usually going to be a lot of appetite at this time. The woman may feel nauseous. She may even throw up or get diarrhea. State of mind during labor needs to have some attention. The mom needs reassurance, relaxation, no problems at this time. If there's an issue that you have, talk to someone outside of the circle. The mother may be embarrassed or too self-conscious to get comfortable in labor if too many people are around. Now, hopefully, during the month leading up into this, she's determined who could be safely in the room and who she would be comfortable with having in the room. And again, going to my own situation, I had requested a friend and my mother and my husband, the midwives and me. And then a friend of my husband's wanted to come in. And I just said no. And I just told him, you're going to tell her no, that's not going to happen. and it was great. I just had the people around me that I wanted to have around me. And it made me very, very comfortable. Labor itself is not just about pushing. The pushing part of it is really just the very end part. Before that, there is contraction to get the body ready to push. And during this time, the woman wants to be free and comfortable and not holding on. She wants that transition to be easy. When the fetus hits the tailbone, we have a natural reflex to push. The head drops further into the birth canal, and there's a natural reflex to push. We can wait for the body to do the pushing. The closest analogy we have is to having a bowel movement. If everything's moving along smoothly, peristalsis occurs and the stool moves easily out of the body. The same thing is true with childbirthing, that if we wait for the body to do its contractions in the way it wants to do them, then the delivery is much more effortless. The challenge comes when we're trying to force what's happening. We may be pushing too soon. Say if we're pushing with each contraction, we may not have any movement. But when the body's ready, the baby moves easily. From Kimberly said the woman who taught her sister's hypnobirth class said to breathe the baby out. Similar to having a bowel movement, no pushing or straining, and had them practice breathing out bowel movements and leading up to the birth. Those clients that she had that were more Vata were probably a little frustrated because they've got a harder time breathing out that bowel movement. But it does make a lot of sense that what we're doing is supporting the body. We have one muscle in the body, the uterus, which is in control of this. If we try to get our abdominal muscles to force the baby out, they're not doing anything. The only muscle that's at work here is the uterus. During labor, we want to keep hydrated and maintain high electrolyte levels. We keep hydrated by drinking water. We keep electrolyte levels up by making sure that we've got either some electrolytes in the water or that we're taking electrolytes separately. We're eating vegetable soups and things like that. We can take easy to digest, nurturing soups, things that are going to move through the body pretty effortlessly. The body's busy right now. It's going through a big transition. This AMA may cause a colicky uterus. And that would cause asynchronous contractions without result. This is going to be, now let me talk about contractions for a minute. When the first contractions come on, this is doing something very different in the body. Usually our body moves towards homeostasis, which is if you get too hot, your body takes steps to cool you down. You get too cold, your body takes steps to warm you up. In the case of contractions, your body is moving in a negative feedback mechanism, which means you have a contraction that has moved you away from balance. So the body says, great, let's do more of that. And it moves you further away from balance. So with each contraction, there's release of oxytocin. The release of oxytocin causes the next contraction to be stronger and come a little bit sooner. So an asynchronous contraction is they begin to take a very predictable pathway. I'm losing my words. So if I have this asynchronous contraction, I have a contraction and the next one, say, is going to be at 10 minutes. The one after that should be about 9 minutes later. And maybe the one after that stays at 9 minutes, stays at 9 minutes, stays at 9 minutes, and then it starts going down to 8 minutes. Eventually, the contractions move from every half hour to every 2 minutes. But it should move in a smooth progression. Asynchronous contractions is where you have one contraction, then the next one may be weaker, or maybe it comes sooner. And the one after that may be stronger and come sooner or a little later. Contractions should be predictable. This is why we can time them. So AMA creates these asynchronous contractions. If we've taken care during the pregnancy, this should not be an issue. We should not have AMA trapped in the tissues still. If we were really conscious, we went through panchakarma prior to the pregnancy, we watched the Agni during the entire pregnancy, and now we're here with relatively ama-free. We can encourage daily elimination, easy elimination, with taking easy to digest foods, fiber, oil, and water, and having regular exercise, squatting to poop, and doing all these things. It's a common occurrence that a woman will have a bowel movement while she's in labor, or she might move small amounts of stool out while she's having a contraction. If, midwives and nurses and doctors, everything are very used to this, they clean it up very quickly and it's not an issue. But for a woman not expecting it, it can be a surprise, or she might be embarrassed about it. So knowing that going in can be beneficial. Taking care during labor. There may be stalls in the labor. There may be some intermittent pain that comes up. The baby may be in an odd position. If you're working with a midwife or an OBGYN, they're going to check that. You're going to know what position the baby's in. There are some methods that they have to move babies into different positions, but oftentimes if you're in a hospital and the baby's in an odd position, then they'll recommend a cesarean section. Changing the mother's position, doing lunges, walking up and down stairs, helps to open the pelvis and to support the baby in moving into correct position. The correct position for the baby is head down and face back. Oops, I don't know my correct position of the face direction, but the head should be down. If the feet are down or the butt is down, that's called breech, and it makes it a more difficult delivery. There are techniques to turn the baby, and these can be done by acupuncturists, these can be done by chiropractors, and they can be done by OBGYNs and midwives, although OBGYNs often don't. It's beneficial for the mother to have an advocate. This might be a doula, it might be her partner, but she needs someone who is willing to interface with other people during labor and make decisions based on her wishes and desires. So modern obstetrics are often not evidence-based. What they're choosing is to reduce liability. Currently in the US, I think our cesarean rate is up over 30%. Now, the World Health Organization recommends that there be no more than 15% of the births by cesarean section, because cesarean section should be used in emergency situations to save the life of the mother, save the life of the child, or in cases where the labor can't proceed. But more and more often, people are opting for these cesarean sections. They reduce liability. The doctors don't have a lot of experience at turning babies from breech to head down, so it's easier. They have a lot of experience at cesareans, and it's easier, but there are challenges with cesarean birth. There's a higher incidence of maternal morbidity in hospital births than with home births. Maternal morbidity is death of the mother, and that's going to occur. Well, one thing I got to say with this, most home births, if they got into a position of it being an emergency and a potential for maternal morbidity, they're going to transport the mother. So I do think there's a little bit misleading in the statistic, because every woman I know has a home birth still has a backup plan of if there's trouble, they're going to the hospital. So I can see that will impact the home birth versus hospital birth morbidity rates. But there's more likelihood of having exposure to other pathogens while you're in the hospital. I knew for myself, being a 43-year-old mom, that if I stepped into a hospital, they'd have me in a cesarean very quickly. So that was my last thing I wanted. So I made certain to have all the things in place. And then we got to a point of my blood pressure was going up a little bit, and my labor wasn't progressing. And there was a question about at what point were we going to transport? And I made a decision it would be in 20 minutes. And he was born in the next 15, so it was like, okay, this is something. So I do think that there is a part of that statistic that may be a little bit off. But I do also know with home births that they tend to have mothers who have done better prenatal care. They have mothers who have been working with a midwife or a nurse midwife, and they've kind of prepared themselves much better than I see in the large population of people. Many women go into the hospital well prepared for labor and delivery, but you'll also find people who haven't done a lot of prenatal care and don't really know what to expect. there's a slightly higher infant mortality with home births, and the challenge here is because home births often lack monitoring. Like, what I mean with that is, if I had been in the hospital, if I was in the hospital at the delivery, they would have had a baby monitor on me and checking the baby's heart rate the whole time. Many home birth midwives do have these devices, but some don't. And so it's possible to be unaware of a situation until after the baby is born. I had a friend who had a home birth, and she had a midwife who was really against ultrasounds. So she had gone through her entire birth without an ultrasound, and then during the birthing process, she needed to be transported. And what was tricky was that she was the one saying, I need to go to the hospital. And everyone else was kind of saying, the midwife, oh, no, this is good, this is normal. And she kept saying, I need to go to the hospital. And it turned out that the placenta had grown into the uterine wall. And had she delivered at home, probably both she and the child would have died, because the child wouldn't have had enough oxygen and she would have hemorrhaged. And so there is a higher infant mortality rate with home births because they don't know a crisis situation is imminent. If they're in the hospital and the crisis situation occurs, they have all the tools right there to support the life of the child. Whereas in the home birth, you don't have the neonatal unit right there. And so that can be a challenge. And they put the percentage difference is very small. It's really up to the individual as to what kind of birth they want to have. I opted for a home birth, and it looks like John has opted for home births, and largely because I felt that was going to be best for me. Being an older mom, I'd already been told by the medical establishment that they would induce me at 40 weeks, and they probably wouldn't let me labor more than a few hours because of my advanced age. And I didn't like that notion that regardless of how well I was doing, because I already presented with my age, they were going to move forward with something that I didn't want. So I knew that I wanted to get into a hospital as late as possible. But it frightened a lot of people. Like, I had one brother who offered to, he thought it was financial, so he offered to pay for everything. My mother was a former labor and delivery nurse, and she loved the idea that I wasn't having a child in the hospital. So it was, there was all kinds of other people weighing in. But at the end of the day, the only person who needs to make that decision is the mother, because she's the one who needs to 100% trust that her decision was the right decision. Another reason to need an advocate, that interventions may not be necessary, and the mother can decide ahead of time whether or not she wants these particular interventions. Does she want the strep B antibiotics? Hopefully she'll have done the research and made a decision that she's comfortable with. When they check for dilation, how they check for dilation is they put fingers into the vagina and they touch the cervix to see how dilated it is. So you might hear people say it's 4 centimeters. That's typically 4 fingers distance that the cervix is dilated. And so they'll be inserting something into the vagina and touching the cervical membrane, as well as if the baby's head is there, touching the baby's head. And it's possible that infection could enter at that time as well. So that introduces infection. You could ask for them not to check for dilation, or at least not to check as frequently. Induction. Induction is when they give you a hormone that's going to stimulate the production of oxytocin and bring on labor. Oftentimes they can induce too soon after missing the due date. I mentioned before the doctor told me that I was seeing for some checkups. He said that, oh no, he'd induce me at 40 weeks. Like, if I hit 40 week to the day, then I was going to be induced. And he was not my OBGYN. I had a nurse midwife, and so he was just someone I was seeing for this assessing the fluids of the infant. So you didn't have to worry about that. But at the same time, this is something a lot of women face, is they're told, oh, at 40 weeks, we're going to induce. If you haven't gone into labor by 41 weeks, then you've got to induce. This is the number one factor causing tears and drops in baby's heart rate. Tears are going to be tears of the vaginal wall. We can take care of the perineum and massage that and getting the body ready. And if they don't know what the factor is that actually starts labor. They don't know if that's a hormonal message from the mother's body, if it's a hormonal message from the fetal body, or if it's a message from the placenta. All they know is that when it starts, that causes the release of oxytocin, causes the uterine contraction, causes the baby to move down into the birth canal. And so there's all these other factors at play. So it's not simply, oh, the oxytocin starts. There is a trigger before that that they have not identified. And so it would be possible for them to have miscalculated the due date and to be delivering early. It may be possible that the baby's not completely developed yet and ready for delivery, or the mother's body is not completely ready for delivery either. So the induction has to be allowed, as far as the mother has to give permission for it. If she has an advocate who says, no, we're not going to do that, then the mother can be comfortable with her decision and know that her wishes will be carried out. Right now, hospital births have a 33% national C-section rate. The home birth industry has a 2 to 3% C-section rate. However, I don't know how that statistic is determined, because they will not do a cesarean in a home birth. I guess if they had an emergency, they would. But they would transport a person. And I don't know if that means, what typically happens when they have to transport is there's often a C-section, because they get to the point where the person can't deliver for one reason or another. And they're far into labor at that point. I do think a home birth, in my opinion, a home birth was preferable to a hospital birth for so many different reasons. But that decision has to be made by the mom. And as a practitioner, I want to fully support her decision. If she wants to have her baby in a hospital with an epidural, that is her decision for her body and her child. And I may say, would you like to hear some statistics about this or anything else? But if she says, no, I really don't, then I have to stay on my side of the street, because this is about her body and her delivery and her safe delivery of her baby. Another reason why they might need an advocate: medical doctors can view situations as emergencies when they're often not. If the cord is wrapped around the baby's neck, this does not mean that the baby has air supply or blood supply cut off to the brain necessarily. If they're delivered and they can get a finger around that and remove the cord, they can be delivered vaginally safely. If there's meconium in amniotic fluids, meconium is the first stool that the baby passes. It's the byproduct of all the debris that the baby has absorbed and has gone through the digestive system, and it's a black tarry stool. It's not supposed to move out of the colon until birth, or until after birth sometime. It's the baby's first bowel movement. And if it's in the amniotic fluids, it's possible that the baby has aspirated some of this, has taken it into the lungs, and that's not a good thing. So that can be a potential emergency situation, or if the baby is breech. So breech is when a normal birth, the baby's head down. It shows head down and face forward. The breech baby has got the bum at the cervix, the feet are down, and the head is up. So this is a breech baby, and it's possible to turn a breech baby. But although obstetricians are taught how to turn breech babies in medical school, they don't practice it often, and so they may feel uncomfortable with the technique, and so may opt for cesarean to deliver the breech baby. If we're working with the medical doctor and we have one of these conditions, it may not be an emergency, and so we want to have an advocate who is able to assess the state of emergency or non-emergency that's present. As it said on a previous slide, most of the decisions in modern obstetrics are made to reduce liability. So if there's a challenge where, if I do the cesarean, I can bring the baby out and I can remove any threat and there's no problem. Or if I do the vaginal birth, there may be a challenge. They're going to opt on the side of low liability. And that's what the mother has to be aware of, the parents need to be aware of, and they can make those decisions about how they want to proceed in these instances. Just because a doctor says you have to do something doesn't mean you have to do anything. By law, you have autonomy and you have control over your body. So the doctor may tell you what the situation is and give you statistics and everything else, but you want to be informed of the fact that you have the final say in anything that happens to you or to your child. More care during labor, needing an advocate. If home birthing, in the Netherlands, they recommend that the mother have an advocate. Health insurance give better incentives, as much cheaper and better outcomes. And home birthing is not encouraged by medical boards. Let's see what this is saying here. In the Netherlands, they recommend home birthing in most situations, and they have a very low cesarean section rate. Health insurance companies can give incentives as much cheaper and better outcomes. I'm not sure what that line is saying. I'll have to figure that out. I know that health insurance companies partner up with hospitals more so than they do midwives, and so they will often give incentives to those companies. I don't know about health insurance companies giving incentives for home births. I found with my own experiences in California that there was no health insurance coverage for home birth. I would only get health insurance coverage for my birth were it to be done in a hospital. So I don't know about that being the case in California, at least not 16 years ago. It may have changed, or it may be different in different states. Home birthing is typically not encouraged by medical boards, of course, because home births are typically not performed by medical doctors. They're performed by midwives, nurse midwives, licensed midwives. You may have some medical doctors who do these, but it's not the norm. Another reason why the mom might need some advocates, that most birthing situations require transfer to a hospital are not emergencies. If the mother has fear, if the mother doesn't have a strong advocate for what's going on or have a strong sense of how labor and delivery are going to proceed, she may interpret some things as emergencies that may not yet be emergencies. Oh, my example is for mine. My blood pressure was coming up, and what they did was they found when I laid down, my blood pressure went down. When I stood up, it came up, which is pretty normal. She was concerned because I'd been in labor for a long time. It had been now over 24 hours. And then we were just concerned, okay, if the blood pressure keeps going up or if it elevates while you're lying down, then it's going to become an emergency and we'll transport. So they can look at something that if someone had just looked at blood pressure, they would say, oh, this is an emergency, we got to go. This was why my friend midwife had a second midwife there. The two of them discussed it, and she deferred to the other midwife saying, I don't think we have to worry yet. And so that was good because her, as my friend, had a different level of emergency and concern than the other midwife did, who didn't know me as well. If the uterus ruptures, that is an emergency. Yes. So this is birthing situations, home birthing situations that may require transfer to a hospital. The ruptured uterus is really rare. It often happens in what's called a VBAC, a vaginal birth after cesarean. And that usually happens only if the previous cesarean hadn't healed well. Most home birthing professionals will have many of the same tools as the hospital. If the baby isn't breathing, they have aspirators, they have things to clear meconium out of the lungs. So they should carry those and have them available in the room. My scary story about that wasn't mine, but it was a midwife that I knew, that she had those tools, but they were in her car. They were not in the room with the birthing baby, and she did not retrieve them in time to save the child's life. So it's just making sure. It's like, are we all set? Everything is in this room that we need. If we're going for a home birth, we want to make sure we have every tool in place, because if you're in a hospital, every tool is in place. Hospitals may force vaccine or other testing on the newborn. They prick the heel to test for vitamin K and blood clotting. It used to be they got a hepatitis B shot because they could get exposed to hepatitis B in the hospital. So you want to check ahead of time. Again, the parent has the say they can refuse these. They put a little silver nitrate in the eyes, which I don't know if they still do, but these are things that you want to check and see what the hospital's policy is, and how can you, if you want to opt out of them, what do you have to do? And if you want to opt into them, is there anything you have to do? All of John's kids were born at home. Yes, 4 kids born at home. I liked home birthing. I did that. And He does mention there's an unassisted birth movement, which he doesn't agree with. And I do know a woman, she had her first child at home with a midwife, and she had her second child at home unassisted, where she just took care of the whole thing. She was young and sassy, and so she did it. The challenge with an unassisted birth is that if there is an emergency situation, it's nice to have a trained professional there who's been through lots and lots of births and can identify what the challenges are. It's good to have an advocate if you're going to the hospital. Bring a doula. The doula can be the go-between between hospital staff and the mother to limit the exposure the mother has to these disturbing conversations. And so, as it says here, this helps to prevent non-evidence-based interventions that lead to C-section. So there's no proof that the C-section is going to have a better outcome than this other. So if I had, like I have said a couple of times, if I had gone in, I knew they were going to do a C-section. They had told me so much ahead of time that because of my advanced age, and I didn't feel like I was at an advanced age, but for them, anyone over 35 is at an advanced age in this. So they become a risk, a pregnancy risk. And so there wouldn't have been any evidence-based intervention. It just would have been, oh, you're old, let's cut you open. And so that would have, I didn't like that idea. So an advocate would be the one saying, no, she's not doing it. If they get to a point where it's an emergency situation, the child's heart rate's elevating, the child's blood stats are not looking good, the mother's blood pressure's going up, those become emergency situations. And that's evidence-based when they can go in and work with that. Having sex during early labor. Semen contains prostaglandins, which are chemicals that support hormonal function in the body, and this stimulates progression in labor. Sometimes people get told when their labor's delayed, when they feel like they want to bring it on, to have sex. Even nipple stimulation creates oxytocin release, and that's going to help to stimulate the labor. It's very important to bond with the baby in the first 15 minutes after birth. Skin to skin is very important. So that means the baby moves, and it's before the umbilical cord is even detached. It's like moving the baby up from its birthing place to being held on the mother's chest. Some babies begin to root around looking for the nipple immediately. Others are kind of exhausted from everything they've just been through. The skin to skin, it's warming. They moved out from a nice warm bath into a cold environment, and I bring them back close to the body. And they're back close to hearing the mother's heartbeat, where that's what they've been hearing for months. If the mother has just been through a cesarean, or for whatever reason this can't happen, we can also do it with the father. If the child needs medical intervention, then it can happen later. But the bonding is so strong in those first few minutes, it can become a very important time for bonding. And that wraps up our third section in looking at the 9th month and delivery. I'm going to talk a little bit more about a fourth section now that's postpartum.